Okay, what are the effects of lateral bending on annular fiber movement? This is a really important slide and important lesson. It's commonly thought both in chiropractic colleges around the United States and out in the field as well, that the annulus moves or bulges toward the convex side of the lumbar spine during lateral flexion. However, research has revealed that the annulus actually moves toward the concave side, and this is due to compression of the opposing vertebral end plates and the taut type 1 collagen annular fibers. So here's a depiction of number one, a subject laterally bending to the left, and then we see here that's a motion unit in left lateral bending or left lateral flexion. So in their book, Clinical Biomechanics of the Spine, White and Punjabi have showed that with lateral bending, the spine, the discs actually buckles and bulges on the concaved or compressed side of the curve, as demonstrated right over here by this little check mark. The disc actually flattens or even draws inward on the convex or expanded side of the curve. So quite opposite to what maybe you were thinking. Most of you were probably thinking that during left lateral bending, the disc actually bulged to the right. But the opposite is true. And again, it's due to the taut, tensile nature of the annular fibers. As the vertebral end plates separate, which I'll just demonstrate right here, as they separate, because those collagen fibers are taut, they actually become more taut and stand straight up or even buckle in, where on this side they get compressed and they buckle outward. Of course, this is true during flexion and extension as well. And again, maybe you were thinking that the opposite occurs, but to the left, right over here, that is someone flexing forward, like in the little diagram of the man to the left. And during that movement, again, the taut annular fibers become straight and actually put pressure driving the nucleus that way. And so the nucleus actually buckles and bulges in the anterior. And that, of course, is why when we have an acute lumbar spine disorder of discal origin, or maybe not even of discal origin, we bend forward to try and find comfort. And then, of course, the opposite is true. When we extend backwards, the disc actually buckles and bulges in the rear. Of course, if we attempted to do that during a disc injury, that would only serve to increase the pain. So maybe something new for you to grasp onto in terms of the biomechanics of the disc. All right, now, what is the nucleus doing? Because we were just talking about the annulus. So oddly enough, the nucleus actually does what you would have predicted that it does. So during lateral flexion, the nucleus, again, in a healthy disc, they always have to study healthy discs without disc degeneration. The disc does displace away from the side of lateral flexion. So in other words, the disc displaces towards the side of the convexity, as you might have anticipated the annulus doing. So let's show you a nice picture of that to clearly explain what's going on here. All right, so to your right, we have an MRI image of the lumbar spine in lateral flexion. And to the left, right over here, this is a kind of a fluid-based MRI image showing how the nucleus during right lateral flexion is actually displacing itself to the left. And this picture here before, here on the bottom, not super important, but this is just a hydration mapping, kind of showing the displacement of the nucleus as a water-based entity. But what I really want you to look at is the next set of arrows. Because even though the nucleus itself is trying to move towards the convexity of this lateral bent spine, you'll notice that the net effect is disc bulging into the concavity. So interesting phenomena. The disc itself as an entire entity is going to bulge into the concavity, but the nucleus is trying to make its way to the convexity, but it can't because the taut annular fibers are containing it. So let's put it together. Research appears to indicate that during lateral flexion of the lumbar spine, the nucleus is displaced toward the side of the convexity or the expanded side. However, the net effect appears to be a bulging of the disc towards the concavity or the compressed side. And of course, this is due to the buckled and bulging type 1 collagen fibers on the compressed side and the taut and stretched fibers on the expanded side. But clinically, what would be of most interest to us, or symptomatically expressive, would be the bulge. You know, where does the annulus bulge? And that is to the concavity. All right, so just want to also make it clear that if you add degenerative disc disease to this equation, the nuclear displacement becomes completely unpredictable. When you have radial fissures and circumferential tears and diminished disc height, it's about impossible to determine. So these are studies that are done on normal spines, or as normal as they can attain. All right, intradiscal studies. This was a groundbreaking study done by Nachemson, published in 1976. They used volunteer medical students who were willing to have pressure-sensitive transducers placed in the nucleus of their third lumbar discs. And then you can see they went into different postures, and the lowest intradiscal pressure recorded was when they were flat on their back. And then the highest is when they were seated in a forward flexed posture with 45 pounds of weight displacing their body and compressing it even further. Point here is, the takeaway is, we don't want the patient to sit, because when they sit, the discs express significantly higher intradiscal pressure than when they're laying on their back side. Let's define the disc lesions. There's two general terms that we would paint with a broad brush to just describe the basis of the injury. And one is contained. And A contained disc lesion is when the annulus is torn, but still restraining the nucleus. So nuclear material has not left the outer annular posterior longitudinal ligament complex. And then we have non-contained, and this is where the annulus is fully torn and has allowed nuclear material to leak out. And we'll show you examples of this, but that material can extrude, sequester, or free fragment into the vertebral canal or the neuroforaminal space. That's where the roots exist. But in essence, what we're saying here is the disc material has left the outer annular posterior longitudinal ligament complex. Okay, so here are some examples. Let's start with concentric or circumferential. All right, so we can see in the coronal view, these red areas here, that's a breach in the elastin that has allowed two annular rings to separate. And then if we look at it in the axial view, we'll just take one example right there, axial or transverse view, that is a circumferential tear. And again, the elastin has given way, allowing separation in that area of the annular fibers, loosening that area, making it more prone to additional injury. And what causes that, folks? Well, there you have it. This is caused by torsion. And you know, we're torsion beings. We're turning and twisting all the time. Simple things like opening a door, you know, opening your car door. You know, you basically, if you're right-handed, you turn to the left. If you're left-handed, you turn to the right. There's just so many things that we do that creates torsion, but excessive torsion will cause failure of the binding elastin and a circumferential tear. And if you get enough of them, right, if they coalesce together, you get what's known as a radial tear or a radial fissure. And you can see this very clearly over here on the coronal or frontal view, and very clear on the transverse view. And of course, this one is still contained, because you can see there's about 1, 2, 3, 4, looks like there's about 4 annular layers that are still containing that nuclear material. But nonetheless, the disc is bulged, and that is going to trigger a response to the sensory guardian of the disc, which is the sinovertebral nerve, and that is going to be recorded as pain. As far as the tear goes, and we'll go into this in further detail, but it's only the outer 1/3 of the disc that is actually innervated. So this area here may actually be causing pain as well, but the closer we go toward the nucleus, there is no pain receptors there, and the patient would not even know there was a tear if it was just within the inner 1/3 or 2/3 of the annulus. It's a nice picture, an in vitro example of a radial fissure or radial tear. And you can see that it is complete, right? It just goes all the way through, and it does show some leaked nuclear material as well. There's another one, another radial fissure. And this is another in vitro example of a posterolateral disc extrusion. This was in a 43-year-old male. It was at the L4, L5 level, and you can see the extruded disc material. You can see it's still all connected, making it a disc extrusion. If this area were to kind of fall off and migrate right over there, then we would have a sequestration or a free fragment. All right, we have something known as rim lesions. And a rim lesion is when there's actually a separation between the periphery of the disc and where it attaches through Sharpie's fibers to the cartilaginous end plate. That's what's known as a rim lesion. And then we have transverse tears, and a transverse tear is a tear that has the potential to split the disc in two, having a cephalid and a caudal section. And there's a good example of a transverse tear. It's basically a horizontally oriented radial fissure, and you can see it right over there. Transverse tear or fissure. All right, and just some more picture examples. That's a protrusion or a herniation, an HNP, herniated nucleus pulposus. And this one is contained, because you can see right over here that there is still, I'm making red dots here. Maybe I'll try and circle it, but yeah. So we still have maybe one or two or three rings or lamella of the annulus containing that disc. And there's the prolapse. And a prolapse, of course, is non-contained, and that means that there's been a complete tear or split in the annulus, allowing the nuclear material to begin to poke out. This would be an extrusion because the material is still connected. If there was a total separation right there, then it would be a sequestration. And if this piece over here, I'll just put a red dot on it, if that piece were to migrate, move right, move left, move up or down, it would then become known as a free fragment. And here's some beautiful examples of disc extrusions. And by the way, Cox technique is effective with these. We don't fully understand why. Remember, we just don't have the research that we need to have. But I've done it myself. The Cox technique is very effective with free fragments, sequestrations, and extrusions. But here is an example of two extrusions, and the definition is listed here: leaked nuclear material that is contiguous or still in contact with the original inner contents. That is a disc extrusion. All right, this was a phenomenal study. Loved this when it came out. And this was the prize winner for that year in 2013 for the National Society for the Study of the Lumbar Spine. And this is the anatomy of failure in lumbar disc herniation. Absolutely love it. Great information here. All right, so what did they do here? This was the first study that provided in vivo, right? So there's two types of research, in vivo and in vitro, right? So in vivo, whenever you see that, that means it was done on living specimens. In vitro, on cadavers. So this was a great study, and it showed evidence that lumbar disc herniation in humans occurs as the result of end plate junction failure. That's an actual fracture. And it did that more often than failure of the annulus. It was about 7 out of 10. I'm going to show you exactly what we're talking about. So they had a study group of 181 patients, and they were all slated to undergo single-level disc surgery. And the surgery of choice was a microlumbar discectomy. We'll be showing you details on that in the future. The thing I like about this study is it was a multimodal study. These patients were treated, in all honesty, like all patients should be treated. And they ran every test under the sun on them. So if you look at it, they did a clinical evaluation. Of course, anyone would get that, which includes a consultation and an ortho and neuro examination. Then they took plain old spine x-rays on them. Then They did thin slice CTs on their lumbar spine. Then they did MRIs, both plain and with contrast. Trust me, folks, you're never going to get that kind of care. All right, then they did an intraoperative examination. So instead of just going in there, plucking out the disc material and closing them up, they looked around. And then whatever they removed, they did a histopathological analysis on. So this, again, was a multimodal study. Here's what they found. Type 1 herniation they labeled as end plate junction failure. That occurred in about 65% of the individuals. So defined in this study as lumbar disc herniation that occurred as a result of damage to the vertebral end plate, not damage to the annulus. We'll show you a picture of it and you'll see exactly what I'm talking about. And there were three varieties of that: rim avulsions, vertebral corner defects, and upper and lower vertebral end plate avulsions. Again, found in 65% of the cases. Here's the rim avulsions. So let's take a look at these. A is a small rim avulsion. You see that little white speck. B, moderate. So what are we actually looking at here? We're actually looking at the end plate busting off of the vertebral body. C is a large one, and then D is what they call complete. So the way the nuclear material escaped in these versions here was it busted right through the bony end plate. The annulus was still intact. So here is what we're talking about. That's the apophyseal ring, and what we're saying is the nuclear material actually busted right through, like that, right through the end plate. All right, the vertebral corner defects, if you look carefully, you can see, if you follow the white area here, you can see the vertebral corner has been punched out. And then if we look at this one, again, you can see the vertebral corner. It almost looks like a compression fracture, but that is how the nuclear material escaped. And then the final one is the upper and lower end plate avulsions, and you can see that clearly over here. A is the lower end plate, B is the upper end plate, and then you can see the actual bony material that busted off at both levels. And again, that's how the disc material escaped, leaving the annulus intact. All right, and then they found, what was considered normal for the day or for the time, and type 2 is annulus fibrosis disruption, and this was found in about 35% of the individuals. So defined as lumbar disc herniation that occurred as a result of the annulus failing, and of course in these cases the vertebral end plates were intact. This occurred in 35% of the individuals. Right, so here's an example. Here's a CT to the left, and you'll notice there's no disruption at all, no disruption of the bony structure at all. But if we look at the MRI, you can see the circled area is a clear extrusion of disc material. And here's some good pictures to kind of qualify what we just discussed. A, of course, is normal, just two vertebral bodies, end plates and disc. B is the type 2. B is annular failure, and you can see over here that the nuclear material just busted through the annulus. C is type 1, and that's the end plate junction failure, and you can see the annulus is intact, but you can see this space right over here where the end plate was breached and the nuclear material leaked out. And here's a really good example of that as well. Again, the annulus is intact, but the nuclear material busts right through the corner of the vertebral body. And here's the histopathologic evaluation of the removed material. And if you look at picture A, the white arrow is actually pointing out the bony end plate, as is the black arrow. And in picture B, the three white arrows are showing the apophyseal ring where that nuclear material busted out through. All right, so a great come away from this study. We all know that the gold standard for lumbar spine diagnostic imaging is the MRI. What we've learned through this study is it's not as golden as we would like it to be, because we've discovered that MRI is not useful in revealing bony fragments in the herniated nuclear material. So if you look at the upper two pictures, A and B, that's a CT. And you'll notice you can see the avulsion of the end plate. I'm just going to put a little line on it right there. And then you can see it over here in the lateral margin. But take a look at the MRI. Look at C, D, and E. There is no evidence whatsoever of any bony fragmentation. So if all we did was an MRI on this patient, we would be clueless as to the fact that they actually had a vertebral end plate fracture. So an incredibly revealing study. This one absolutely kept me sleepless for days on end, and I had to do a PowerPoint presentation. I felt it was so important to present this to the student body. Okay, if you've ever wondered how discs heal, wonder no more. We're going to take you through the basic process. Let's start out with a left posterolateral disc protrusion. Let's point out some of the anatomy that we're looking at. These little projections here, I'm just going to color one of them in red. Those are the endings of the sinovertebral nerve, so those would be the nociceptive nerve endings, and you can see they go in. It's fairly shallow. Most authors say it's about a third of the way in. And what you're seeing over here, this is the protruded nuclear material right there, and then the red is actually inflammatory cytokine response. So let's enlarge that. And again, you can see the terminal endings of the sinovertebral nerve, or their nociceptive nerve endings. You can see the protruded nuclear material, the protruded disc material. Not only is it triggering back pain from the sinovertebral nerve, but there's also pressure upon the neurovascular bundle, and that is likely causing radicular symptoms, some type of sciatica. The red also indicates the secretion of chemokines, and chemokines are inflammatory chemicals that are secreted anywhere in the body where there is tissue damage. And they do two things, and they're both important. Number one, they lower the firing threshold of the affected nerves, so they make it so the area is exquisitely painful and tender, and of course that's a protective mechanism. But number two, and it is extremely important, is they stimulate angiogenesis, or neovascularization, which is the formation of brand new blood vessels. Let's take an enlargement look at that. So here we have the neovascularization, or new blood vessel growth, going directly into the protruded material and deep within to the nucleus. And what's going to happen is macrophages are going to come through those new circulatory channels. They're going to secrete an enzyme called matrix metalloproteinase. And that enzyme is going to begin to somewhat liquefy and break down the type 2 collagen fibers in the nucleus. So the macrophages and the phagocytes can basically gobble it up and take it out through those new vascular channels. And as they do that, it's going to begin to diminish in mass and quantity, and the disc is going to begin to shrink. And that would be the end result right there, where we see granulation scar tissue in gray. It takes about 90 days, but in all honesty, discs need about 6 to 12 months to fully heal. And so we try and warn our patients. As a matter of fact, I just had one that did not heed my warning, and I hate when this happens, but they were about, it was either 30 or 45 days into being completely symptom-free, and this gal decided that she was going to rearrange her closet, which involved a lot of forward bending and turning and twisting, and she pretty much exacerbated her condition. And she's a little more unhappy than I am, but we're both not thrilled about it. All right, nerve root displacement from disc protrusions. You're familiar with this. This is kind of just a review, and in case you're not, it'll give you the information you need to become familiar with it. But we know with a disc protrusion that compression on the nerve root is going to create antalgic muscle spasm, and it's pretty much going to form a scoliosis to the left or to the right, sometimes straightforward. But it's an innate response of the body to put the least amount of strain on the involved tissues. And discs can go medial to the nerve root, lateral to the nerve root, or they can go directly anterior to the nerve root. Let's show you a little bit more about that. All right, so to the left is a medial disc lesion, and you can see it in red. Right there in red. Okay, let's go ahead and erase that now. All right, so that protruded disc material is medial to the nerve root. So to try and get away from it, to try and lift that nerve root off of that medial disc, the patient is going to lean into it. I put this little reminder here, me too, or medial toward the sciatic side. All right, the next example is right here. Again, I'll just draw a little line and then erase it. All right, so there's your lateral disc lesion. That disc is sitting lateral to the nerve root. And again, to try and get away from it, the patient is going to bend away to try and pull that nerve root away. So for a lateral disc, they bend away. So look that away, or look that away. Just some things that maybe will help you to remember that. And here's the 3 varieties. Again, to the left, we've got the medial, right there, medial disc, lateral disc, and this is subrhizal, this one right here. And so that's a posterolateral disc protrusion effacing the anterior aspect of the nerve root. Those patients will come in bent forward with unilateral sciatica. Obviously on this side they would have left-sided. All right, the nerve disc relationships, you should be familiar with these, but the discs typically affect the next descending root, not the exiting root. So an L3 disc, when it protrudes, affects the L4 nerve, and L4 disc, when it protrudes, affects the L5 nerve, and an L5 disc, when it protrudes, affects the S1 nerve. Why is that the case? Well, this is the best picture I've ever seen. So here we have an L4 disc, right? Just put a check mark over there, L4 disc, and you'll notice that the disc anatomically sits under or beneath or lower than the L4 nerve root, right? There's the L4 nerve root right there. So when that disc protrudes, it actually goes under that nerve root and it hits the next exiting root, which is right over there. Put an X right on it, right over there. So that's the mechanism right there. There is an example to, an exception to that. Okay, so let's look at the picture on the left, figure 1, right there. All right, so the blue circle is showing a descending L5 nerve root. And of course, if there was a posterolateral disc protrusion in this area here, it would affect that root. But if there was a far lateral disc protrusion, in other words, if the disc protrusion or extrusion went laterally, that's what we would see here in this red circle, and it would affect the exiting root. And here's an example of it to the right. That is a far lateral disc extrusion, right? Remember, this is an extrusion because the extruded material is still contiguous, right, with the original material. But you can see that because it went far lateral, it's affecting the exiting nerve root. Those are usually not treatable. Unfortunately, they're rare. They usually require surgical intervention. All right, so the patient management tip for the day, we go back to this study by Nachemson, is don't sit if you have a disc. You rest on your back or on your side, whichever is more comfortable. And just, some interesting points from the study, right? Here we have someone bent forward and the intradiscal pressure at L3 is 150 pounds. All right, now here's someone with 45 pounds of weight in their hand bending forward. Now tell me you haven't done that before. That's a horrible check mark. Let's see if we can do a better one. Tell me you haven't done that before. Bent forward into a trunk to pull out a bag of dog food or a bag of fertilizer or, whatever you have. But when you do that, you just increased intradiscal pressure by 70 points. Bingo. That's dangerous. All right, and look at this one seated. All right, there's someone seated, 185 millimeters pressure at the L3 disc. Put weight into their hands, again 45 pounds, and now we get a 40-point increase. Point being is some of these postures are dangerous and best be avoided, but the thing that we really want you to take home from this is, as part of your patient management, tell the patient, do not sit, not even in recliners. We want them on their back or on whatever side is comfortable, and then they can switch between those two, and that will assist them in the healing process and actually speed up the healing process. Give them less visits, less cost for their condition. All righty.